This content is AI generated for informational purposes only and should not be directly used for clinical decision-making.
Hello and welcome back to the Neurosurgery Hub podcast. I'm Dr. Aris, Senior Attending Neurosurgeon.
And I'm Dr. Alara, Research Fellow. Today we're looking at a fascinating new study from the Journal of International Medical Research published in 2026, titled Somatosensory Evoked Potential Monitoring for Position-Related Brachial Plexus Injury During Cerebellopontine Angle Tumor Resection, a retrospective cohort study.
This is a topic that hits home for anyone who spends long hours in the OR. When we talk about cerebellopontine angle, or CPA, tumor resections, like vestibular schwannomas or meningiomas, we usually focus intensely on the cranial nerves. We're worried about the facial nerve, the vestibulocochlear nerve, and the brainstem. But this paper reminds us that the patient's positioning can be just as consequential for their postoperative quality of life.
Exactly. The study highlights that while we're focused through the microscope, the patient's peripheral nerves, specifically the brachial plexus, are under significant stress due to the specific positions required to access the CPA. Most of these surgeries are performed in the lateral decubitus, or the park bench position.
Right, and for those listening who might be juniors, the park bench position involves the patient lying on their side with the down arm tucked and the up arm often positioned to allow the head to be rotated and flexed toward the floor. It gives us a great corridor to the posterior fossa, but it creates two major risks for the brachial plexus: compression of the dependent arm and stretch of the non-dependent arm.
That's the core of this retrospective cohort study. The researchers looked at a large series of patients to see if somatosensory evoked potential, or SSEP monitoring, could effectively catch these injuries before they became permanent. They specifically monitored the median and ulnar nerves throughout the duration of these long CPA cases.
It's a smart use of existing technology. We already have the ION-MM, intraoperative neurophysiological monitoring setup for the cranial nerves. Adding upper extremity SSEPs isn't a huge leap in terms of equipment, but the study suggests it's a huge leap in safety. Ella, walk us through the SSEP criteria they used to define a significant event.
Of course. The study adhered to the standard 50-10 rule, which is widely accepted in neurophysiology. A significant SSEP chain was defined as a 50% decrease in the amplitude of the cortical or subcortical potentials, or a 10% increase in latency. What's interesting in this 2026 data is how frequently these changes were actually positional rather than surgical.
That's a key distinction. In spine surgery, we use SSEPs to make sure we haven't compromised the cord. Here, the SSEPs are acting as a check engine light for the patient's shoulders and arms. Did the study specify when these changes usually occurred?
They did. In many cases, the changes didn't happen immediately upon positioning. They often occurred an hour or two into the surgery, likely due to a combination of slowly developing ischemia from compression or the gradual settling of the patient's body weight against the axillary roll.
The axillary roll, that's a classic surgical pitfall. If it's placed too high in the axilla, it compresses the brachial plexus directly. If it's not there at all, the weight of the chest collapses the dependent shoulder. This paper really emphasizes that the SSEP gave them a window to intervene. What did the surgeons actually do when the SSEP technician gave them the warning?
This was the most actionable part of the study. When the 50-10 threshold was met, the surgeons didn't just stop the resection, they performed a positional intervention. This included loosening the tape on the shoulders, slightly adjusting the rotation of the head, or repositioning the dependent arm. In the majority of cases in this cohort, these maneuvers led to a recovery of the SSEP waveforms within 10 to 15 minutes.
That's the save. If you don't have that monitoring, the patient wakes up with a numb hand or a weak deltoid, and you're left wondering if it's a peripheral nerve issue or something more central. By the time they wake up, the damage is done. Did the study show a correlation between the SSEP alerts and actual postoperative deficits?
Yes, they looked at the true positives and false negatives. They found that patients who had persistent SSEP changes, meaning the waveforms did not return to baseline despite intervention, were significantly more likely to have a brachial plexus palsy or sensory deficit postoperatively. Conversely, in the group where the SSEPs recovered after repositioning, the incidence of post-op deficit was nearly zero. It proves that the warning works if you act on it.
It's interesting that we're seeing this in 2026. For a long time, some centers felt that SSEP for the arms was extra or unnecessary for cranial cases. But when you consider that CPA surgeries can last 6, 8, or even 10 hours, the cumulative time of compression is the real enemy.
And the study also touched on the non-dependent arm. We often worry about the arm the patient is lying on, but they found that excessive traction on the top shoulder to get it out of the way for the surgeon's comfort was a major cause of ulnar nerve SSEP changes.
I've seen that in the OR.
The surgeon wants a better angle, so the resident pulls the shoulder down with tape. It looks fine on the skin, but the brachial plexus is being stretched like a guitar string. This paper really advocates for a more dynamic approach to positioning. It's not set it and forget it.
Exactly. They even suggest that for high-risk patients, those with a high BMI or pre-existing cervical spondylosis, SSEP monitoring for the brachial plexus should be considered the standard of care in lateral or park bench cases.
Let's dive deeper into the statistics for a moment. For our residents listening, what was the incidence of these SSEP changes in the study?
The researchers reported that about 6.5% of the patients in their cohort experienced a significant SSEP change related to positioning. That's not a small number. If you're doing 100 CPA cases a year, that's 6 or 7 patients you're potentially saving from a debilitating nerve injury.
And in the repositioning group, how many of those 6.5% actually saw their signals come back?
About 85% of them. In those cases, the intervention was successful. The remaining 15% where the signal didn't return usually had a higher rate of transient neuropraxia, but even then the study noted that knowing the injury occurred intraoperatively allowed for earlier physical therapy and neurology follow-up.
That's an excellent point. Even if you can't fix the signal, the information is power. It changes the post-operative conversation with the patient. Instead of being surprised by a weak arm, you can say, "We noticed some nerve stress during the procedure and we're already on top of it."
The paper also mentioned the importance of the baseline. They recommend taking the SSEP baseline after the patient is fully positioned and the head is in the pins, but before the incision is made.
That's crucial. If you take the baseline while they're supine on the stretcher, it's useless. You need to know what the new normal is once they are twisted into the park bench position. If the signal is already 30% down just from the positioning, you might want to adjust the patient before the first cut.
To summarize the paper's conclusion for our listeners, SSEP monitoring of the median and ulnar nerves is a reliable, non-invasive way to detect and prevent position-related brachial plexus injury during CPA tumor resections. It provides a real-time feedback loop that allows surgeons to adjust these surgical ergonomics in favor of their patient's peripheral nerve health.
It's a great reminder that neurosurgery is a whole patient specialty. We can do the most beautiful microneurosurgical resection of a tumor, but if the patient can't use their hand to write or eat because of how we position them, the surgery isn't a total success.
Well said, Dr. Aris. That's a wrap on this study from the 2026 Journal of International Medical Research. It's definitely something for all of us to think about next time we're at the head of the bed prepping for a long posterior fossa case.
Thanks for joining us on the Neurosurgery Hub podcast. Stay tuned for our next episode where we'll continue to dive into the latest literature shaping our field.
See you next time.